So welcome to the Let's Talk Clots 23 United Kingdom Clinical Pharmacy Association session looking at DOACs in cancer-associated thrombosis. My name is Katherine Stirling. I'm consultant pharmacist in anticoagulation and thrombosis at Leeds Teaching Hospitals and co-chair of the UK-CPA Hemostasis, Anticoagulation and Thrombosis Committee. I am very excited to be joined today by two other committee members who will be presenting this session for us. So Nathan Hutchinson-Jones is the lead pharmacist for anticoagulation and thrombosis at Royal United Hospitals in Bath. He leads a team of specialist nurses, manages a cancer-associated thrombosis clinic, so perfect for today, and works alongside consultant haematologists in dealing with patients with complex anticoagulation needs with previous unprovoked or provoked thromboses and recurrent thromboses. And he's the research lead for our HAT group. Also joined today by Kieron, and Kieron is the principal pharmacist for thrombosis and anticoagulation at Swansea Bay University Health Board, Morrison Hospital. He also runs the acute VTE service, as well as doing clinics in cancer-associated thrombosis and other specialist areas, and on behalf of the haematology department. Kieron's team have been recognised for their work in improving the care of patients with cancer-associated thrombosis. So we're very lucky today to have two such expert speakers. Please send in your questions on the question and answer button at the bottom of the screen. I will keep an eye on those, and we will have some time at the end where we can ask Kieron and Nathan any of the things that you want to know. So please do input those questions so that we can ask at the end. And now I would like to hand over to Nathan, who will start their talk today. Thank you very much.
Thanks very much, Katherine. I think Kieron's going to start actually, but just to confuse things. That's right. We'd like to just, throw your kilter there. So no, it's going to be Kieron. So I'll let Kieron start.
Thank you, Nathan and Katherine. I'm just going to leave both my and Nathan's disclaimers on the screen for a second, just while I just set the scene a little bit. Thank you for Thrombosis UK for asking us to speak to you today. On our topic, which is exploring quite a topical issue, I would say, which is around the use of DOACs in cancer-associated thrombosis. So I think that we've seen a lot more of DOACs being used now in cancer-associated thrombosis, and in turn there's a lot of questions and a lot more things for us to look at in terms of factors, in terms of deciding. So hopefully we can go through some of the evidence with you from that respect and maybe give a little bit of our own experience. So we'll be chipping in as we go along with what we do locally within our services as well. So I hope you find it useful, and like Katherine said, if you have any questions, please input them into the question box. So just very broadly, just in case you're not aware, what are we actually talking about when we talk about cancer-associated thrombosis? Well, it's fundamentally when we talk about any venous thromboembolism which is associated with active cancer. And that can even include patients within 6 months of having treatment for active cancer as well. So whereas historically we may have thought of these as just VT, we are now moving to a mindset where we're starting to think about patients with active cancer and being treated with VT as being a specific subset of VTE patients. And VT in general, well, generally applies to deep vein thrombosis and pulmonary embolism, but actually we tend to see VT in all manner of the venous areas of the venous system, upper extremity DVTs, splanchnic vein thrombi in the abdomen, venous sinus thrombi. There's a whole range of thrombotic events that we see within the spectrum of cancer-associated thrombosis.
I was going to just ask you there, Kieron, as well, that I know we're focusing really on VT here, aren't we? But I assume, do you have patients in your clinic as well who have, sort of cancer-associated stroke as well, sort of ischemic stroke? Are they sort of patients that you might see sort of arterial thrombus as well?
Yeah, absolutely. And you're right. I mean, we're fundamentally, like you said, we're focusing this largely on the venous side of things. But yeah, these patients are hugely prothrombotic. And actually, you're right. We see a whole manner of patients with a variety of events, and it links in quite nicely actually what you're saying there to sort of this idea of cancer-associated thrombosis, because I've done a number of talks recently, and apologies if you've heard me say this before, but I'd like to get that message across, which is I continuously pose this question, which is, do we need to manage our patients with CAT any different to people in the general population in terms of general medical patients? And I think both myself and Nathan are pretty much sold on this, that we do.
I'm
Otherwise
desperate
we
to say
wouldn't
the
be-
answer. I'm desperate to say the answer there, but yeah, it's a really good point. There's a reason, I think, isn't it? Obviously, we both have dedicated clinics really for these patients, don't we? And I think that sort of suggests, doesn't it, that what the answer is to that question, really. But I'll let you carry on.
No, I agree. I'm glad you said yes. But so I've got 4 good reasons why we should consider them to be different. I usually give 7. We haven't got time for 7. I've finished my favorite 4.
Cut it down. Yeah,
We've cut it down for today. So what are those 4 reasons? Well, the first one is that cancer-associated thrombosis is actually quite a common complication of cancer therapy, and often it's maybe not thought to be as prevalent as it is. And this was actually taken from the local media within South Wales, where it managed to get into the headlines with this figure here, which is 1 in 5 of our cancer patients will develop a blood clot at some point throughout their cancer journey, and that could actually be a fatal event. So 20% of our cancer patients will go on to develop a VT at some point. So again, if we're looking at this as an issue, it's a very prevalent issue, which means that we should be taking it seriously from that perspective. And just to add a little bit to that, well, actually, if we look at causes of death in cancer patients, well, actually, cancer-associated thrombosis or thrombi are the 2nd most common cause of death in cancer patients after the tumor itself. And to add to that, we know that if one of our cancer patients goes on to develop a VT, we've seen from registry data that actually the survival rates for those patients are lower in the patients who go on to develop CAT compared to the ones who don't. And also, if we just think about a risk factor for VT in general, well, cancer is probably one of the most important risk factors. And what I mean by that is not just in patients who have cancer, but if we have a patient who has an unprovoked VT, for example, one of the key things that we need to do is do a bit of digging to see if there is an underlying cancer there causing that event. And likewise, we undertake a whole manner of interventions in this patient group, which increase their risk of having a VT. And we all know Viakov's triad. I'm not going to give you a lecture in this, but I think the thing I want to get across with this slide here is that when we think about Viakov's triad and those 3 elements which lead to patients having clots, cancer is probably one of the conditions which affects all aspects of the triad quite uniformly. And so what you have is this patient, through a whole manner of factors, becomes a very procoagulant patient and is ultimately a very high risk patient for developing a clot. So that's the first thing. We know that because of the nature of the condition, our cancer patients are far more prone to have clots, and we will see a reasonable chunk of our cancer patients ending up being in something like mine and Nathan's care under our cancer-associated thrombosis services. But there's also complexities in the management of these patients. And I alluded to this a little bit earlier in terms of the fact that we know from data that our cancer patients who develop thrombi have seen reduced survival in studies. Well, we also know that looking at the Riete registry data, which is quite a good resource in terms of registry data, we know that the rate of fatal PE in our cancer patients is considerably higher than what it is in the non-cancer patient group. And likewise, we need to anticoagulate these patients, and we know that as a result of that anticoagulation, the rate of fatal bleeding is higher in our cancer group than it is in our non-cancer group. So not only are these patients so much more prone to having clots, they're also far more prone to become into harm as a result of the clot. And in this case, we're talking about fatal PEs, but also as a result of the anticoagulation we initiate them on, they're at a far greater risk of having a fatal complication of that treatment. So again, I hope this paints this picture of what we're talking about here. Now, I always like to use this image, and I think if we're looking at a visual summary of the scale of the problem, I think this summarizes it quite nicely, because this was work which was done locally, where I'm sitting right now in Morrison Hospital, and this is looking at clot microstructure between non-cancer patients to early stage cancer to advanced cancer. And you can really see this far more tightly bound fibrin-rich clot in the advanced cancer patients than what we see in the other patient groups. So Nathan, I tend to like this just as a sort of summary, really, or visual summary of the scale of the problem that we face with these patients. And like I said, I think, hopefully that from that perspective shows just how challenging these patients really can be. And I tend to find them far more complex than what I would see from the other cohort of patients I see in my clinic, which are my general medical patients.
Yes, no, I completely agree, Kieron. I think you're summarizing it really well, actually. And yeah, I think, based on everything you've said so far, it just doesn't sound surprising at all, is it? Of course, they're going to be more complex when, as you said, the higher thrombotic risk, higher risk of recurrence, higher bleeding risk. And, and I like this slide as well. I think it's really interesting to see that actually, the type of clot itself and its structure is different as well, isn't it? And I imagine there is probably a lot of unknowns still as well, isn't it, in the context of cancer-related VT. So yeah, they are very difficult. And I would agree with you that overall they are more difficult and complicated to manage, I would say, than a general population. I would agree with you on that, yes.
Yeah, absolutely. And likewise, to add to this complexity, the third point in terms of why you should treat them differently. Well, if we think about a general, and I keep saying general, what I mean is a non-cancer VTE patient, there's generally quite a predictable thrombotic risk profile with them in terms of the fact that at the point they develop their VT, they're very high risk of recurrence, especially within that first month. That then will gradually decrease with 3 to 6 months of anticoagulant therapy, and their risk then long-term will largely be dictated by what caused the clot in the first place. But the challenging thing with the cancer group of patients is it's quite a dynamic process. And again, I really like this slide for showing that, and I think I stole this from you, Nathan, so I appreciate
I was just going to say that I really like this slide as well, but yeah, okay, that makes sense then.
So we see the spike in VT occurrence within the first 6 months after diagnosis, but again, it's a dynamic process. Patients with curative intent will see a reduction in that thrombotic risk, and those are the types of patients where we think about stopping after 6 months. But in the event of patients who are in the palliative, or rather have palliative intent treatment, it's likely if they remain having active disease, that risk is going to continue to be there for the rest of their life. So again, add into this complexity that they're not this fixed risk profile. It's very much a dynamic profile, which is dictated by the disease status and the interventions.
And the other thing I was going to mention there, Kieron, was that I feel like we have so many patients these days as well who have not necessarily gone into full remission, but their cancer is a very low controlled level with some kind of treatment and that's controllable for a period, but inevitably they will progress eventually. So I always find they can be challenging sometimes, particularly if they've had a cancer-related VT, because you think, well, do I take them off because it's at such a low control level? But inevitably it is going to progress eventually. But I think, it's sort of, it's difficult, isn't it? It just changes. And I think you might be the same as well. I mean, we follow up patients, up to 6 months after their VT diagnosis, but actually a lot of the data we've collected at the RUH would suggest that patients continuing long-term anticoagulation who still have cancer do benefit from ongoing input and review, because things change, don't they? And it's difficult. It is.
Yeah, and I agree, and that's why we've set up these longer term services to keep these slightly more sort of longer term patients under our care.
That's it, and it's an extension almost, isn't it, of a lot of that work done, showing that benefit of a CAC clinic follow-up up to 6 months. And actually, we've both ended up in the same situation where we probably inevitably kept hold of some patients longer, and then and it kind of makes sense, doesn't it, that actually they do need longer term follow-up because of these changes, isn't it, with their treatment, with their cancer, with that presence of metastatic disease. So another challenge, really.
Absolutely. Linked to that as well, at the moment, we're just speaking to you about cancer-associated thrombosis as a homogeneous group, but we also know that there's different risk profiles with different tumors in terms of both thrombotic risk and bleeding risk. Now, we'll go into the bleeding risk a bit later because that's quite relevant to the overarching theme of the talk. But especially from a thrombotic perspective, we know things like pancreatic cancers, lung cancers, brain cancers are particularly high risk from a thrombotic perspective. And we have now started to see strategies of prophylaxis in certain high-risk groups. So brings us on to the fourth point, which is probably the most important and the thing that we're fundamentally speaking to you about today, which is this idea that we now have DOACs as an option in terms of treatment. And on this slide, you can see a range of guidelines here. But what you'll notice is that most of the guidelines which are post 2018 have now included DOACs within their first-line treatments, where all the guidelines before that suggest low molecular weight heparin as the treatment of choice. And what we'll go into in a second is that I think fundamentally, when we talk about DOACs as being a treatment option, I think from a patient perspective, patients are very happy about this because it's an oral option, but we'll go into in a second some of maybe the pitfalls of thinking that. But I think what you're going to see as we go through this is that actually from a clinician perspective, I think it's fair to say that maybe it's added things, making things a little bit more complex from our perspective. And actually we're now asking questions which we weren't asking previously when our only option was low molecular weight heparin. So before I hand over to Nathan, I'll go through those nuances, just a little bit around, well, why are these treatments of choice? So a little bit of revision around the data. So when we talk about low molecular weight heparin as being the treatment of choice historically, this comes from the CLOT study in 2003. I won't go into the detail of the study, but the key factor was, as I'm sure you're aware, if you're involved with CAT, was in terms of efficacy, in terms of reduction of recurrent VTE, it showed that dalteparin performed better than warfarin, but with a similar bleeding profile. The second study then was the CATCH study, which was tinzaparin against warfarin. Actually didn't meet superiority from a statistical perspective, but was numerically superior in terms of efficacy. There was a little bit of a thought around how the study was powered to achieve that. But again, established low molecular weight heparin as one of the treatments of choice, as the treatment of choice rather, in cancer-associated thrombosis. And more recently, we've got enoxaparin, more recently gaining its license from a slightly different study. Again, I won't go into this in depth because I could probably spend a bit of time on this study. But just that this was a matched cohort study, again, based on Riete data, comparing enoxaparin to dalteparin or tinzaparin in the other arm. Actually performed quite well in terms of recurrent VT, but there's a higher rate of major bleeding, which seemed to be more in that BD regime. So the more recent development has been DOACs, and I mentioned 2018 as being the year because that's when the first two DOAC studies were undertaken. The Hokusai VTE cancer study for edoxaban and the SELECT-D study for rivaroxaban. Prior to this, there was this sort of thought around cancer patients being included in these big phase 3 studies, but these were the first dedicated studies being where the DOACs were being compared to the gold standard treatment of dalteparin. And actually, interestingly, from an efficacy perspective from these studies, well, the DOACs seemed to perform very well. But there were concerns around bleeding rates being higher. So in the Hokusai study, an increase in major bleeding. In the SELECT-D study, it was in clinically relevant non-major bleeding. And when we dig a little bit deeper into the subgroup analyses, which we'll go into in a second, what we noticed was there tended to be a spike in GI and GU malignancies. And with the SELECT-D study, there was a slight change in the protocol, which maybe meant that we didn't quite see it so much with the major bleeding factors. But as a result of these studies, it did show that DOACs are a good option in cancer-associated thrombosis, but opened up this new question around primaries of cancer primaries, and whether that meant that there needed to be slightly more individual care from that perspective.
I think with all studies, isn't it, Kieron, it's always important to look at what sort of exclusion criteria they had, and what kind of patients they included. And I think cancer patients, it's such a broad group, isn't it, with so many different patients with different things to consider, that you almost have to go in depth looking at the data then to reassure yourself about which patients are appropriate, particularly when they're so high risk, isn't it? So it's having that confidence, I think, to use DOACs really, and that's taken a little bit of time, I think, hasn't it? For particularly, I think, thinking about some of our oncologists, it was a little bit of time for them to get used to the data and actually to feel comfortable with using it, because we were so ingrained with low molecular weight heparin. So
And I think it's quite interesting as well with the efficacy side of things, because often the feedback I get is that, well, low molecular weight heparin is assumed to have better efficacy. Well, that's not what the studies are showing. The concern is the bleeding side of things. That's where we saw the concerns.
And it's interesting, isn't it? Because sometimes when we have recurrent VT on a DOAC, I mean, we often change to low molecular weight heparin.
Yeah, we do.
So one could argue, I suppose, you might have an argument for trying a different DOAC, couldn't you, based on that data with the efficacy? But I know from our perspective, we like low molecular heparin. We tend to stick with that full initial 1 month dose, for example, and we can titrate it up further with 10A levels. So that's our rationale. But you know, it's just, you know, based on the data, you would think actually the DOACs look better, don't they? But then again, you have to think about the patients they've included as well, don't you? And what, you know, so.
But yeah, I agree, and I think we tend to do the same as you ultimately. And that leads up to the most recent study, which was the Caravaggio study, which was apixaban, non-inferior in terms of efficacy, numerically superior, but didn't reach statistical significance. Slightly different to the other studies, a pretty similar bleeding profile between the two drugs, slightly lower major bleed in the apixaban group, but slightly higher clinically relevant non-major bleeding, but actually from a bleeding perspective seemed to perform relatively well. And then, similar to what you said, Nathan, it's very difficult to make head-to-head comparisons because we don't have those head-to-head studies, but you know, that there has maybe from a sort of general VT perspective been an assumption that apixaban possibly is a lower bleeding risk drug, which is why maybe these results aren't so surprising from a bleeding perspective.
Yeah, it's sort of not completely dissimilar thinking about the studies been done in non-cancer patients, is there, in terms of overall bleeding. So yeah, I would agree with you that even though you can't directly compare, I mean, the apixaban study, it probably looks a bit better overall, doesn't it, to be honest?
Yeah, I think especially from a bleeding perspective, as we said. But as a result of this, and this is again pre-Caravaggio, so this is 2018, the ISTH came up with a recommendation suggesting that we avoid DOACs in cancer patients who are high bleeding risk, and they've defined that based upon that initial study data of being luminal GI cancers or GU malignancies primarily. And especially with the upper GI malignancies, which Nathan will go into in a little second about the specific considerations there. So at this point, I'm going to hand over to Nathan at this point to carry on the discussion, if that's okay.
Yeah, that's great. Thanks, Kieron. So certainly, we do have more guidelines now, really, don't we, supporting the use of DOACs. And I think, you know, both you and I, Kieron, have been involved in developing consensus guidelines around this, haven't we? So, and there's a lot of them available, and you know, I think we've got more and more evidence, more and more recommendations now for their use. But I mean, really, isn't it? It's all very well as talking about these studies, but I mean, how on a day-to-day basis, how do we choose which patients are appropriate? Because it can be difficult. I think as a general sort of step-by-step process, I mean, certainly initially, I mean, of course, one of the things you have to consider is there a contraindication on the non-cancer perspective? So are they significantly renally impaired, for example, you know, in which case all of them would be contraindicated. So you have to consider all of the usual cautions and contraindications. But then from a cancer perspective specifically, the initial thing is you really need to think about what cancer does this patient have? Do they have an intact primary? And that's important, particularly thinking about bleeding risk, but also as well, we know some cancer types weren't represented as much in some of these studies with the DOAC, so we don't have as much data. And we also know that some cancer types have are particularly prothrombotic as well. So things to think about there. And then of course, there are additional risk factors that some cancer patients may have. So for example, thrombocytopenia, which might be disease related or could be secondary to the patient's systemic anti-cancer therapy. And that might be something that fluctuates or changes. And again, that then presents its own challenges in how do you manage anticoagulation in someone with fluctuating platelets and variable bleeding risk. Interactions, also something really important to think about, particularly when there's very little data or information about a lot of the interactions. And of course, we're getting newer and more treatments available for cancer patients. So, you know, little data often about those and how they might interact as well. Absorption can be an issue, particularly for patients maybe who've had resection. And of course, really importantly, not to forget patient preference as well. And we've got a little bit of data about that we'll come on to shortly. So just as a very brief summary, this sort of summarizes a little bit a couple of those slides that Kieron talked about. I mean, overall, when we combine all of those studies that we've seen together, DOACs certainly significantly seem to reduce the rate of recurrent VT, and they seem to be better than low molecular weight heparin. So they seem effective. But again, there were exclusion criteria in these studies. Some cancers weren't included, or some cancers weren't represented. And certainly some patients, so for example, we know that, I think, Kieron, you might be able to tell me if this is correct, but I'm sure, for example, patients with less than a 6-month prognosis and very advanced disease, I don't think they were represented very well in those studies from, I'm sure it's 6 months or something was, I think in Caravaggio, I'm sure they had to have a prognosis of longer than 6 months. So there are groups of people that aren't represented there. So we have to bear that in mind. And the reason I mentioned that one is that is probably a group of patients based on your graph, or that graph that you showed, Kieron. We know that the risk of recurrent VT, and VT goes up, doesn't it, with more advanced disease end of life treatment. So there are caveats in here that we have to sort of comprehend. But certainly overall, there was a increase to some extent in bleeding, and it was a bit variable, as Kieron said, between the different DOACs. Apixaban a bit more comparable, certainly from that major bleed risk, but certainly there were higher rates of clinically relevant non-major bleeding, and with the other two studies, higher rates of bleeding, particularly in certain cancer types, as Kieron mentioned, particularly GI and urothelial. So if we talk a little bit more about tumor type initially, so as I say, the primary tumor type is a risk factor for VT, bleeding, and also VT recurrence. So it's really important to consider. We know that there were higher rates of bleeding in upper GI cancers. There were also higher rates, particularly in the rivaroxaban and edoxaban studies with lower GI with intact primaries as well, and also in those urothelial genitourinary cancers as well. I think it was, Kieron, you did touch on this or mentioned it briefly, is the rivaroxaban, which was the SELECT-E study. I think the upper GI cancers, they actually excluded them at a certain point, didn't they? Yeah, because there were high rates of bleeding. So, I mean, certainly you're probably the same, Kieron, but in our practice, and I think most guidelines, consensus guidelines would recommend that low molecular heparin is probably preferred really in upper GI cancers, although certainly the Caravaggio study, it did include upper GI cancers, and the bleeding risk did seem more comparable with low molecular heparin. So, it might be an option, but certainly I think I always feel that there were limited patients in that group in that study, and I think I still prefer low molecular heparin personally in upper GI. Is that what you think, Kieron, or do you do something different?
Yeah, I do, and exactly like you're describing there with low molecular heparin. I think you're right. There was a very low number of patients with upper GI malignancies in Caravaggio, and I have in my practice observed GI bleeds in that patient group when we've used DOACs. And in fact, even patients who are on DOACs who are not known to have malignancies but develop upper GI bleeds or GU bleeds, sort of hematuria and such, cancer is in the back of your mind, and especially knowing some of this data, it does prompt you to at least consider that as being a cause of the bleeding.
Yeah, no, absolutely. And I must admit, Kieron, I've not had great experience of using a DOAC in upper GI cancers, and it's never been first line, but I think, sometimes we've partly been swayed by patient preference, and some patients who are completely needle phobic and just can't, and it's difficult, isn't it? Sometimes you have to, you explain the risks to the patient, but I am quite nervous. And pancreatic cancer, I think as well, is a cancer I worry a little bit about, because I think, again, one of the graphs that you showed earlier, Kieron, you had pancreatic cancer, I think, as the highest rate of VT, I think, didn't you? I think it was right at the top. And I do find them very prothrombotic. And I do often find that lots of them, particularly with advanced disease, will end up needing escalated doses of low molecular weight heparin with 10A monitoring as well. So I think combined with a higher bleed risk as well, I find low molecular weight heparin a bit of a safer option, I find in that. But then again, difficult group of patients to manage, because often very aggressive disease, often they lose lots of body weight, they often really struggle with the injections. It's very difficult. But certainly overall, I think when you think of lower GI cancers, then I'm quite happy to use apixaban in that group of patients. I probably wouldn't use edoxaban or rivaroxaban based on the study data that we have. I suppose you could consider it perhaps if they'd had the primary removed, although I think there was some study data that came out that suggested there was still a higher rate of bleeding for a period after that. I mean, personally, I would stick to apixaban in someone with a lower GI cancer, ideally, although I suppose you might, if someone who's intolerant to apixaban and doesn't want to have low molecular weight heparin, you may end up perhaps considering a different one. But certainly with an unresected primary tumor, you would probably want to avoid that. And we've used quite a lot of apixaban in lower GI cancers. And actually, I think in the Caravaggio study, there was a big group of lower GI cancers. So that's quite reassuring, isn't it, Kieron?
Yeah.
But certainly, and again, the urothelial cancers as well. I do use apixaban for urothelial cancers, actually, which I'll come on to in a moment. I think there were slightly higher rates, particularly of non-major bleeding in those groups. But I found that actually, personally, apixaban I don't find that I have any higher rates of bleeding compared to using low molecular weight heparin normally, but it is something to think about anyway. Another group of patients, particularly thinking about patients who are very prothrombotic. So we mentioned the pancreatic ones. I think the other group, which is quite relevant, partly because they weren't really included in the studies, is those patients with brain tumors, essentially, isn't it? Primary brain cancers. In fact, I don't think they were included in any of the studies. I think with the DOACs, were they?
So I oddly, I looked at this recently. There were 22 patients across SLECT and Hokusai VT cancer, and none in Caravaggio because it was an exclusion criteria.
Exclusion. And when you think 22 out of, there was about 1,000 patients in
Hokusai,
I think. Okay, so very, very small numbers. And then I suppose the other group is not just primary brain tumors, but also patients with metastatic brain disease, isn't it? So for example, we have lots of breast cancer patients who end up, metastatic disease, brain metastases. And I think, we know they're very prothrombotic, and also as well, they are quite bleedy as well, aren't they? So it's difficult, really. And certainly, if you look at some meta-analysis data, then we know that there is increased rates of intracranial bleeding. This is interesting, actually, isn't it? Because it says there's a 13% increased risk with metastatic disease, but a lower rate of 6.4 actually with a primary, isn't it? So I don't know. Do you find that surprising? Maybe I'm being a bit, but it's interesting, isn't it? There's obviously a difference there.
So I think it's similar to what you said. I think this is possibly one of our most complex group for a variety of reasons. The prothrombotic element, the bleeding risk, and the functional element as well. When we think about the ability to be able to self-inject and such as the disease progresses. But the more recent evidence suggested that the spontaneous rate of hemorrhage with primary brain cancers, as you see here, is lower than what you see with metastatic brain cancers.
Yeah, absolutely. And I think they're obviously, even though they're excluded from the original trials, there certainly is observational data, isn't there, that I think is quite positive, particularly when we're thinking about using DOACs in this group of patient. Certainly, we know that high-risk primaries associated with bleeding and brain metastases. You've got a number there, haven't you? So like melanoma, you've got thyroid cancer, renal cancer, and all of them require essentially individual decision making, don't they? And I think I suppose you can't say just because they've got that type of cancer that it necessarily is a definitive decision then on the choice of anticoagulant, isn't there? There's variability within each, isn't there, that you have to think about. So when you look at some of the studies that we have, a lot of it is sort of observational retrospective analysis, isn't it, really? There's obviously some data around glioblastomas, so primary brain tumors, where there's lower rates of intracranial hemorrhage in the DOAC arm. So that's quite interesting, actually. That would look very reassuring. But again, we have to appreciate this wasn't a randomized control trial, was it? So observational. And when we look at primary brain cancers in general, there seems to have been a lower risk of bleeding, certainly, particularly with apixaban. So, there is data to support use, I think, of DOACs in CNS malignancy, isn't there? Is probably the overarching thing. There's got to be an air of caution, Kieron, I think, hasn't there? But there is some data.
I think that historically, and I mean, I'm talking about my practice, but when I've spoken to other units around the UK, it's always been a case of, it's very much an individual decision around whether to anticoagulate primary versus metastatic, if there's any degree of hemorrhage anyway.
Exactly. I
think historically we've used low molecular heparin. In primary brain cancers, especially with the more recent apixaban data, I have in some instances, but sort of having a really good think about it, used apixaban. I've not used any of the others.
I haven't either. And to be honest, my go-to is normally apixaban anyway.
Yeah.
But I find with the primary brain tumors, I sometimes, if they're diagnosed quite early on at the beginning of their diagnosis and they're going to have quite a lot of sort of invasive treatment, I tend to have them on low molecular heparin initially and then change them to apixaban. That is often what we sort of end up doing. So I'm thinking about, when they have things like gamma knife radiotherapy and things. And the other problem is sometimes, this leads us on quite nicely to the next section actually on thrombocytopenia. Some of the drugs as well. So I'm thinking of things like temozolomide and things, which actually you do often get quite significant platelet drops. So it's a difficult one. I mean, I think thinking about brain metastases from sort of other primary cancer types, then I think, I have used apixaban in those groups reasonably well, often because a lot of the time they tend to already be on apixaban if they've had a VT and then they've subsequently developed metastases later on. So that sometimes has been, the situation we sort of end up with. But anyway, I imagine this might be an area we might get more data on in the future. So I'll just carry on moving along, because I feel like I need to pick up the pace a little bit. So, so step 2, so additional risk factors. So thrombocytopenia, low platelets. I mentioned it earlier that these can fluctuate, particularly if they drop. Obviously, there's an increased risk of bleeding. Again, thinking about the exclusion criteria in these randomized control trials, a lot of patients would have been excluded. Certainly, patients who generally, I think it's generally thought that above 50, you can use full therapeutic DOACs or anticoagulation, as long as there's not any other bleeding or other concerns. Locally, we would probably reduce the dose if it's below 50 but above 20 to either a 50% dose or a prophylactic. I'm happy enough to use apixaban or DOACs in patients with platelets above 20 at a prophylactic dose sometimes. I mean, although in some occasions we do find it a bit easier to manage with low molecular weight heparin. I don't know, do you ever continue prophylactic doses of DOACs, Kieron, out of interest below 50?
Most of my experience has been above 50, if I'm completely honest. So locally, I haven't used them below 50. It's tended to be low molecular heparin I've used instead in those groups.
I think it's a bit of an unknown, isn't it? And it's tricky. I mean, I think, and obviously you might have some patients who are intermittently have low platelets because of their treatment, and then you get others with advanced disease where actually their platelets aren't going to pick back up, and then and obviously if they drop so far, you're in that situation then, regardless of the choice of anticoagulation, you going to give them platelet transfusions to try and get their platelets up to and able to give it, or actually it can get I feel like this can get really complicated. But I think generally there's not loads of data about DOACs. Some people may prefer to use low molecular heparin, I think, in thrombocytopenia, particularly if it's significant. Certainly, I don't think anyone would really use anticoagulation of any dose below 20. But I think above 50, most people would certainly, and maybe some attenuate doses above 20. And as I say, certainly in our own practice, we have continued some DOACs above 20, but below 50, but at lower doses, essentially. Renal impairment, another important consideration, given all of the DOACs are renally excreted to some extent. Apixaban, the lowest renally excreted, and actually, I mean, probably has some good data generally in renal impairment. Dabigatran, I mean, it's interesting, Kieron, we've talked about DOACs, but I suppose really when we talk about DOACs, we're not really including dabigatran, are we? Because we don't have any data in cancer. So really, I suppose perhaps we should have said factor Xa inhibitors might have been, the way to describe it. So we wouldn't use that one anyway. So we'll ignore dabigatran. But essentially all of them are contraindicated less than 15. And again, you may have patients where their disease is called renal impairment. You may have fluctuations based on the type of treatment they're having, or they might just become acutely unwell, and actually their kidney function might drop. There's loads of other factors as well, isn't it? And again, there's limited data based on study data specifically within cancer. So, generally, I think most patients with reasonable renal function, we're fairly confident. But if you think about patients with renal impairment, i.e. creatinine clearance below 30, we don't really have lots of information really, Kieron, do we? You know, it's a lot of it's extrapolated, I think, isn't it? You know,
absolutely.
from non-cancer patients really. So again, difficult. But certainly, you know, I think I would use a DOAC in someone with 15 to 30 mils per minute with some caution. Personally, I would prefer a apixaban, but I mean, there's dose reductions for rivaroxaban and edoxaban, isn't there, Kieron? You know, so I mean, they're not contraindicated. And I think the other important thing to mention is that if you do use low molecular weight heparin, if you're using a therapeutic dose, it doesn't necessarily mean that's completely safe either, because actually that can accumulate, particularly if you're getting below 20 mils per minute, I think towards 15. And, you know, you may need to do split reduced dosing and 10A monitoring ultimately. So that's not completely straightforward either. So I think that's always important. Sometimes I feel people think switching to low molecular heparin will just be safer and easier. And then you sort of have to explain that actually it won't be, because you need to do dose reduction and monitoring. So important to remember that as well. Liver impairment, important, also likely to affect the safety and effect of anticoagulants. DOACs overall, I think, are acceptable and preferred in hepatic impairment as long as it's not significant enough to contraindicate their use. And all of the DOACs will have contraindications based on LFTs. I think a lot of them, Kieron, were with deranged LFTs were excluded, weren't they, from a lot of studies? You know, so a lot of it is kind of because we don't really know. So we're not really sure. Particularly, you know, hepatocellular pancreatic cancers may be at an increased risk of hepatic impairment. So that might be disease driven, might change. I mean, I'm not a massive fan of using, as I say, DOACs in pancreatic cancer anyway. I probably have used some apixaban in hepatocellular carcinoma. But again, I think you have to be very careful, combined with bleeding risk, clotting risk, and hepatic impairment. I think you're sort of mounting things up, aren't you? You know, and in that situation, low molecular heparin might be more appropriate. But certainly, you'd want to do monitoring with LFTs, albumin levels, and you might want to use a Child-Pugh score as well to try and better estimate that degree of hepatic impairment. Absorption is another thing to think about, and interactions. Already touched on that interactions can be a little bit difficult really to judge how clinically relevant they are, but you have to appreciate that there's not just the chemotherapy drug, it's all the supportive stuff that goes with it. They might be on an immunotherapy in combination or on its own, and of course they've got all their normal meds as well. So there's quite a lot of things to think about, and I think, you know, certainly Kieron, you might be the same, but as a specialist pharmacist, it's something I get asked about quite a bit in the context of CAT, and sometimes the answer is a bit like, well, you know, maybe it's not really very clear, and I think you have to just use your best judgment then, don't you? And you know, patient preference, and you know, what are going to be the implications of using low molecular heparin? Because ultimately, I think if you are concerned or not sure, I mean, low molecular heparin from an interaction perspective is going to be safer, isn't it? Really, ultimately, you know, you can't deny that. And obviously, the different types of interactions, I mean, a lot of them center around P-glycoprotein transporter and CYP3A4, don't they, basically? So they're going to be those drugs mostly that modulate those transporters and enzymes, essentially, that are most likely to interact. Although edoxaban is not affected by CYP3A4. So I suppose, Kieron, you could argue that in some cases where actually, you know, a drug is perhaps likely to affect CYP3A4, but not expected to affect P-glycoprotein, you may prefer edoxaban, mightn't you? I suppose, theoretically.
Yeah, and I think we've got a good example with that in terms of this interaction here, which you at the end of the lutamides interaction, actually.
When you said it, I was like, I'm sure that's enzalutamide. yeah. So go on, Kieron, what do you do with enzalutamide? What's your normal practice?
So it's a little bit difficult one with enzalutamide because it's a strong inducer of CYP3A4, but it's got oddly, it's in vivo and in vitro effects on PGP are slightly different. So it's felt to be an inhibitor in vitro, and possibly an inducer.
That's not really helpful, is it? That's really confusing, isn't it? But anyway.
And we have no outcome data for the interaction. SPCs don't specifically reference anything, but it is ultimately a theoretical concern for rivaroxaban and apixaban. But interestingly, with regards to actually edoxaban, there are some consensus statements out there, which is what the reference on the bottom of the screen there is, that show that possibly edoxaban is an option which could be considered.
Yeah.
So
Yeah.
the issue, however, is, if we're talking about it being an inhibitor, we're going to have higher serum levels. Bleeding risk is going to be a concern in a patient with, what effectively would be classed as being a due malignancy. So we've got that bleeding risk concern automatically. So, I'm a bit more pragmatic about it. I have used edoxaban in my patients who have been on low molecular weight heparin a bit down the line. And fairly stable. In the acute phase, I do tend to initiate them on low molecular weight heparin initially, because at least we get some sort of unaffected anticoagulation during our acute phase before thinking about it a bit on the line then.
And you know what, Kieron, the other thing that this comes up is that people, of course, who are already on anticoagulation for another reason, but then started enzalutamide. This is the group I get asked about loads, and in those patients, I've often changed them to edoxaban.
Yeah,
so same here. Yeah, absolutely. That's a good example, though, I think. And obviously, there's so in terms of checking for interactions, you've obviously got this cancer drug interactions through Liverpool, and they've got a couple of different ones actually, haven't they, for different things. But I've used this occasionally, I think. But
well, bit of bad news.
Oh,
it's actually, as of last month, been shut down.
Oh, you're joking, really?
Yes.
Oh no.
So it's last updated on June 2022. You can still access it in archived form, but you can't get any new interactions, and that's a real shame because it was a fantastic resource.
Oh, that is a shame. I can't believe that.
Yeah.
Oh dear. Okay, that's good to
So
know.
bit of bad news related to that. So we're now, for up-to-date information, we're limited to SPCs, BNF, PK studies.
It's difficult, isn't it? And you end up having to just try and gather as much information as you can and then make a logical decision, isn't it?
Yeah.
Absorption as well is the other concern. I mean, I suppose theoretically, well, there's a couple of reasons why absorption might be a concern. I mean, if you're having a lot of nausea and vomiting with your treatment, you're going to worry a little bit, aren't you, about whether or not that, particularly if you're in a high risk period immediately after quite a significant VT, then again, that might be something to think about. Obviously surgery, people who've had resection, and it depends a little bit because obviously it varies, doesn't it, in terms of what people have had done and how extensive it's been. And I think even when I mean, if you take a Pixaban, I mean, a lot of them, they're not absorbed solely in one place, are they? Although some are more than others. So I suppose, again, you could do a level, couldn't you? I suppose. I mean, do you ever do levels? I mean, any more key? I mean, do you do them occasionally, or I mean?
I do, and actually linked to this, if I'm honest, which is what you spoke about there, which was the absorption issues, because like you said, I mean, apixaban actually has a slightly different absorption profile to the other DOACs in terms of the fact that it's slightly more duodenal, less gastric, whereas the others tend to be quite
more gastric.
Absolutely. So what this is actually taken from a completely different setting. This is taken from the ISTH consensus on post-bariatric surgery. But considering upper GI resections within cancer, I think it still holds true here in that sort of some procedures which are purely affecting the gastric mucosa, apixaban seems to be okay, but the others aren't. Anything which bypasses the gastric mucosa and the duodenum, such as RYGB procedures, seem to affect the absorption of all DOACs. But interestingly, apixaban's got some colonic absorption as well. And there's a bit of a thought that possibly there's a reduction in absorption in people who undergo colorectal resections as well, especially quite proximal resections. So I have sometimes, from the perspective of absorption, done levels because I think it's quite a clear idea on why we're doing it. We essentially want to see how much, from a pharmacokinetic perspective, is getting into their system. And I found, interestingly, the people who undergo total colectomies, who then have ileostomies with high output stomas, we get really low levels of DOACs in those serum
I suppose
levels.
It's not surprising, really, maybe when you think about it. But I mean, I think I'm probably the same as you in that I don't do them routinely, but I have done sometimes, particularly if it's quite extensive surgery. I haven't seen this table before, actually. I've got a slightly different one, but I wonder if it looks not that dissimilar. So maybe it's a different format of the same thing. But I think where it's been quite extensive, and particularly where we're treating quite an acute VT, then I think I always think that maybe, you know, it is within, and they're difficult to know how useful they are sometimes, isn't it? Because obviously the therapeutic ranges are not completely clear. I'll just crack on a bit because I think we've not got loads of time left. Enteral feeding tubes obviously is another consideration, isn't it? Particularly when patients can't have oral intake. And again, it depends a little bit, doesn't it, on, I suppose, the type of tube that you're using and the drug, really, doesn't it? So in terms of how you administer it, and again, whether you expect there to be any absorption issues, and that could also be with you know, interesting with the Pixvan, obviously, if you're giving it with some food or supplements, whether that affects the absorption as well. So there's factors there to consider as well, isn't there? We've got a few slides now on patient preference. I wonder whether, Kieron, you want to do these couple of slides, because I think they're yours. So so I don't know whether you wanted to. I think we've got about 10 minutes, so I don't know whether you could do this in less than 5, maybe.
I'll do this fairly quickly, so we got some crisis. Essentially, so you know, there's all these clinical characteristics about which agent we choose, DOAC versus long-liquid heparin. But the critical point is, you've gone through all this in your mind. You've got the patient sitting in front of you. What do they want? There is data around this, and Professor Noble did this, who works locally in Wales, looked at patients and what they want from their cancer-associated thrombosis treatments. And interestingly, the thing that they value the most is that it doesn't affect their cancer treatment. The second thing they value is that it's effective. It stops them from getting more clots. The third thing is bleeding. And actually, whether it's injectable or oral, was only of moderate importance. So that wasn't the primary thing that they're concerned about. So I think sometimes we sit there going, we want to give them oral. It's not necessarily what they want. And is there actually any data which shows the patients prefer oral? Well, if we think about conditions outside of cancer where we use injectable therapy, like osteoporosis, there was a general preference for, interestingly, oral therapy. But interestingly, people also quite favoured injectable therapy if it was less frequent. So instead of a weekly bisphosphonate, people preferred the idea of a 6-monthly subcutaneous injection. And I think when we think about the factor 11s coming in and some of the longer acting agents there, that might be something which becomes a bit more relevant down the line. And likewise, if we think about anticoagulation with thromboprophylaxis, again, post hip and knee replacement, well, we've got that injectable versus oral option already. Generally, given the choice, and especially because the better efficacy, I think it's fair to say, with oral treatments, most people chose oral as being the option because they found it easier and less complex. So again, I think it goes with that idea that we've got patients who fundamentally would prefer an oral treatment, but actually, I think it's more important for them to have a safe and effective treatment, which goes in line with everything we were talking about earlier. And we shouldn't lose sight of that either, because that is what they really want to get from us in terms of these consultations. A couple of very quick things at the end to finish off with. This debate, are DOACs licensed in CAT? I think it's somewhat open to interpretation. It comes somewhat from the low molecular heparin licenses. You have to bear in mind that the licenses in low molecular heparin are to do with extended treatment, which I've always interpreted as being the treatment beyond that acute phase. So in acute VT, we use low molecular heparins initially before historically we initiated warfarin. The extended licenses in cancer are to do with using it beyond that point and towards the 6-month point. There isn't a specific element in DOAC licenses with regards to cancer, but they are licensed in VT, and Rivaroxaban has always had this particular line in their SPC around, being quite selective around which cancers to use it in, and that links into the data we told you earlier. Interestingly, Apixaban updated its SPC after Caravaggio to say again about selecting. Adoxaban hasn't. They still have that warning saying they don't have any data. So my interpretation is that they're not off license, but there isn't a specific license per se.
And I think importantly, Kieron, isn't it, that nice to say that you can use DOACs as an acceptable option, absolutely. I think. So it's and important to remember that, I think.
And the other question, which again, we don't quite have perfect answers for, do you dose reduce with Rivaroxaban and Apixaban? well, we've got 12-month data with the Doxaban, and fundamentally it doesn't have a dose reduction. Rivaroxaban, there was only a small number of active cancer patients in the Einstein Choice study, which was 10 versus 20, and the SELECT-D 12M study, which was the study between 6 and 12 months for Rivaroxaban, only studied the 20 milligram dose. I tend to use the 20 milligram dose unless there's particular bleeding concerns.
I would agree.
Apixaban, less certain. The license is only for 2.5. The Caravaggio study is 6 months. We're waiting on APICAT. APICAT will give us the answer to that. And I think it's next year. Or is it later this year? Later this year.
Yeah, I think so. I mean, and again, I tend to use 5 unless I'm worried about bleeding. So if they're like 50 kilos and anemic, and then I'm like, okay, maybe we'll drop it. Yeah. So,
I tend to use 2.5 actually because some of the lower risk cancers.
It's really interesting. I say, oh my gosh, Kieron, we should do a study. We should compare our data. Anyway, sorry, we digress.
And just to finish off, I think, myself and Nathan have been strong advocates for this idea of CAT clinics, because there's algorithms which are fantastic, but gosh, we've spent an hour here talking about the complexities of this step by step. If you've got a patient, you're trying to dissect all that data, working in dedicated CAT clinics and having those, I really think that they're hugely beneficial. And if we didn't think they were beneficial before, when we only had low molecular weight heparin, well, now they've got a huge role to play with the DOACs being involved. So, in summary, DOACs are available. They're a good option, but there are a lot of nuances with this. And I think, there's a lot to think about in terms of practicalities and the data. And I think having things like CAT services really do help to support patients to get the best out of these treatments.
Absolutely.
So that was our discussion. Are there any questions for us then?
There are. Thank you so much to both of you. A fabulous double act. I'll have to book you again. I really like the banter going on as well. I've learned lots and I've written lots down as well. So we have a DOAC clinic within our anticoagulant service, where we will see, I saw a pancreatic cancer patient on Tuesday, along with some AFs that have bled and all sorts of other bits, but we don't have a dedicated clinic. And I think you make a good point for that. I think it is a complex area. I think you've covered some of the complexity stuff incredibly well. And hopefully people will feel they've had some answers to questions, but there are a few that maybe you haven't quite covered that would like answers. So the first question was actually around sort of other therapies and the interaction of DOACs, and they put anticonvulsants. I think you obviously discussed the enzalutamide, which has been one of our what do we do with that one? And I do use a Doxaban as well in enzalutamide patients that can have it. But this was around, they've mentioned phenytoin. I think carbamazepine is often an issue with the bigger doses. So just about which DOAC is suitable, or maybe a better a way of asking would be, if you've got a patient with an acute VTE and CAT that's on an anticonvulsant, does that make you think differently about your initial treatments, and then might you change later on? Kieron, do you want to? You're nodding through. I mean, I tend to go with low molecular heparin acutely, because again, I think we're talking about this dynamic process in terms of the thrombotic risk, in terms of cancer status. In that acute phase, you really want to get their anticoagulant therapy right. So I tend to think low molecular heparin initially. Down the line, Doxaban again, Apixaban to an extent with phenytoin. Also, Rivaroxaban's completely contraindicated in the SPC anyway. But again, I think you're going to be very selective around which patients you're going to choose for that, because if you've got these high risk cancers, if you've got patients who got sort of huge saddle emboli, you're probably going to extend the low molecular heparin therapy for a little bit longer with those patients. Great. Yeah, Nathan, anything else? I think that's probably what I'd go with.
I agree as well. I think low molecular heparin would be safer, particularly in such a high risk group. And then I think edoxaban I would probably go with then. So yeah, agreed. Yeah,
that's what we tend to use as well. Seems to be able to have had trouble with Apixaban or Rivaroxaban, just not getting any levels that look like anything that I feel comfortable with in that. So that's great. So thank you for that question. You covered this a little bit, but I think another one just to talk about LFTs and choice of which anticoagulant if you've got deranged LFTs. I think there's a whole multitude of deranged LFTs and what they mean. Is it an unhappy liver or a not working liver and things, I guess, with your baseline coag, and if you've got any ascites and the bilirubin and what the levels are. So what do you look at particularly in those patients to decide whether you feel comfortable with a DOAC, and you know, sometimes if you start low molecular weight heparin because they are so deranged, when might you switch? Nathan, do you want to go first with that one?
Yeah, it's a really difficult question, isn't it? Because I think you have to think a little bit about what's likely causing that derangement in their liver function. Is it actually disease in the liver, or is is it likely liver disease associated with an increased bleeding risk? What's their clotting like? I think you can obviously have transient elevated ALT, bilirubin for lots of reasons, and I think it's really, really difficult. The other thing I should say is that sometimes we've had CAP patients where their LFTs have started to go off, and then we've ended up notifying the oncologist because subsequently it's meant that actually they're progressing on their treatment. So there's, you tend to work as a team as well, how you feed all that information. So you're almost working alongside them as well by feeding that information through. But I think there's a lot of unknowns, really. I mean, I think in patients with advanced sort of liver disease where there's proper derangement and actually you're concerned about bleeding risk in particular, then low molecular weight heparin, I think, is really going to be your safer option if they can tolerate it. And I suppose if you're getting those kinds of patients, then they're probably going to be the patients with more advanced disease, aren't they, or poorer prognosis, one would think, because if it's associated with the cancer, then it probably means their cancer is progressing or is quite aggressive, or if they've got cancer and actually they've also got a completely shot liver, which is not working, I mean, they're probably not going to have a good prognosis from having cancer on top either. So I think, any situation, I think, where you are concerned about bleeding risk, then I think low molecular heparin is probably going to be a safer choice. That's what I would say anyway.
Yeah, thank you, Kieron. Anything extra on there?
All I was going to say was, the assumption with liver disease is that there's going to be two effects. One is in terms of the metabolic function from the anticoagulant perspective, their ability to break them down. The other thing is the synthetic function in terms of clotting factors. Actually, ALT on its own isn't great for guiding the treatments because, like Nathan said, it could be transiently raised for a variety of factors. But the bigger problem is cirrhotic patients, and so we know those patients are both highly prothrombotic and high risk of bleeding, and people often lose sight of that prothrombotic aspect.
Yeah.
So that's where DOACs are ultimately contraindicated, especially Child-Pugh C, Rivaroxaban's B, but Apixaban's okay. So there are subtle differences in terms of where they've been studied and the licensing. But like Nathan said, once you hit that point, it's a very short prognosis, and you've got a very delicate balance there. And historically, I have tended to use low molecular heparin there.
Yeah. Thank you. Yeah, I think that's what we have tended to do. But yeah, it's a really tricky one, isn't it? Especially when you get a coagulation screen that's all over the place, as well as your liver function, and you're trying to balance it. Thank you. That's really helpful. So one of the other queries we obviously talked about, you talked about creatinine clearance and contraindication of the DOACs at creatinine clearance less than 15 mils a minute, and the complexity around low molecular weight heparin, and obviously accumulation potential. So just in an outpatient setting, have you got any tips for managing a patient with poor renal function, so creatinine clearance of less than 15 mils a minute, in terms of treatment for CAT? What do you do in your clinics with those? Kieron, do you want to?
Yeah, we tend to use low molecular weight heparin below 15 mils per minute. DOACs, well, they're not licensed in the UK. Interestingly, in the US, especially from an AF perspective, that they are, but we haven't got that in the UK. So the problem is, Nathan hit the nail on the head in terms of people often lose sight of the fact that low molecular weight heparins also are at risk of accumulating. We use tinzaparin, which below 20 mils per minute, there's this thought that we should be doing 10A levels. What we've observed is 15 seems to be the sweet spot in the patients we see, where below 15, I tend to use the lower dose of 125 unit per kilo with 10A levels to check for accumulation. Between 15 and 20, I've tended to use full dose with 10A monitoring. It seems to hold quite steady. But actually, practically from an outpatient perspective, it's generally okay, because the biggest issue we have is timing with 10A levels, in terms of the fact that both getting that 4-hour peak and the amount of time it takes for the level to come back to be able to interpret it and modify any dosing. And that's the biggest challenge, a practical issue, if I'm completely honest.
Thank you. Nathan, anything else to add?
Just to say that, I mean, we use delta power in, so it's slightly different, but I mean, I would do a 10A level normally in anyone with a creatinine clearance of less than 30. I wouldn't necessarily reduce the dose straight away. If it's above 20, I just do a 10A level. If it's less than 20, I normally go down to 70 units per kilo twice a day, which is not, I want to say a made up dose, which sounds terrible, but it's kind of like a rough estimate, isn't it, about a sufficient dose reduction. The other thing I would say is in terms of practicalities, I mean, I think 10A level monitoring is probably something that needs to be organised through the secondary care service. I don't think I think it'd be difficult for primary care really to sort that. So we would organise those levels with patients, and we normally actually and as you say, the main thing is getting the timing correct actually. So ensuring that actually they've had their dose at the right time and them come in for the correct time. And I think if you're interpreting a level, it's always important just to query that it was taken at the right time if it's really abnormal.
Yeah, that's a good tip. I think the other thing I'm interested in, and when we're looking for it, so we use enoxaparin, which is definitely more renally excreted than the other two, and there's a dose reduction at less than 30 mils a minute, so 1 milligram per kilogram once a day. And though that doesn't seem to get great peak levels to start with, it's definitely, when you've had someone 2 or 3 months on, they've definitely needed a dose decrease, especially if their creatinine clearance is less than 20. Do you do peaks and troughs? Because I must say we would check a trough in our, as well as a peak in our per renal function patients if we can, depending on the time they inject it, to check for that accumulation, because you can often see that gently rising up, and then obviously you've got that more anticoagulation more of the time, which is the bleeding risk. So you both discuss more sort of peak levels by the sounds of it, but interested to see, do you do troughs as well, Kieron?
No, we tend to just do peak, if I'm honest.
I sometimes do a trough, and partly because of I think a discussion I had with Jig, who's a consultant pharmacist in King's, and then I was like, oh, maybe I should be doing troughs then. But I think I do mostly peaks. It's just sometimes in those patients perhaps who are really poor renal functions, and I sometimes will do both. But it's sometimes also the practicalities, isn't it? So it depends a little bit, but occasionally, yes.
Yeah, no, thank you. So I've listened to Jig as well, and so we go for more troughs. So my renal pharmacy team would definitely propose troughs in their sort of poorer renal function patients as well. We are a bit over time, but we have got a little bit extra just to answer these questions. So if you're able to stay with us to hear the end of the questions, that's great. If you need to go, hope you've enjoyed the session. So another question around monitoring and around DOACs, and you did touch on this, and DOAC monitoring of levels. You obviously talks about, we know what sort of we expect, whether that how therapeutic that means it is, but we've got the levels there. So you mentioned a little bit about patients, but you might do those in, I mean, we've done them in enzalutamide, we've looked at it with carbamazepine, which I think we've touched on. You've also touched on it, which I thought was around the absorption for patients that have had gastric surgery of different types as well. I think that's interesting because we've gone with apixaban if people have had stuff done to their stomachs, because we think that seems, and then I have had a patient with a high output ileostomy that had great apixaban levels, so can be a little hit and miss as well, can't it? But I guess in the acute phase, if you're concerned about absorption or interactions which might reduce your dose, you're going to leave them on low like heparin. So if you were introducing a DOAC where there was uncertainty either around absorption, maybe, I mean, you talked about the NG tubes, and we know rivaroxaban, we've had difficulty trying to get good rivaroxaban levels when you're giving it through an NG tube to get the food at the right time and things. So when would you do them, and would you repeat them? Or if you got something that looked okay and the patient was stable, you go, phew, right, great, carry on. What do you do within your practice, Nathan?
I'm always a bit skeptical about how useful they are. I feel like a lot of the times I've done it, I'm like, oh, okay, great, and then I'm a bit like, I'm not really sure, like, it's okay. Yeah, and I'm always a bit skeptical about how useful they are. But I think the times I do them, or I have done them, have been a lot of the time to do with absorption, because I just want a bit of reassurance that they are getting the drug. So I don't think I would necessarily do repeated levels for most patients. I mean, if it's to do with absorption, most patients I've done it's normally after they've had like quite extensive surgery, and I just want something just to reassure me that they are getting some on board. I suppose, I mean, I guess if things are changing clinically, and depending on what the reason is you've done the level, then you may need to repeat it. I mean, certainly sometimes, for example, going to low molecular weight heparin, if I've got someone who's had a recurrent VT on anticoagulations on an elevated level, I do sometimes repeat the levels like every few weeks, like once a month, I'll do another level just to keep an eye on it. But I think with DOAC levels, I mean, I wouldn't normally have someone on a DOAC if they'd had recurrent VT anyway on an anticoagulant. So it really is, I think, absorption mainly. I don't think, I suppose if there was a possible interaction maybe, but I think mainly I do it from an absorption perspective, to be honest. And I normally do a peak. I do normally do a peak for the DOACs.
Thank you, helpful. Kieron, anything else to add, or do you do anything differently?
No, it's largely the same. The only additional time that I do them is DOAC failures in terms of therapeutic failures. Again, I'm with Nathan. We have to bear in mind that we have these levels, that there's ambiguity in ranges. Ranges are fundamentally what they took from the phase 3 studies. We can't correlate it to outcomes. We haven't got any data to change doses. So it's kind of like Nathan said, is where is it useful? And I think absorption is useful because you have a particular concern about a particular issue in terms of a level being lower than you'd anticipate. So if it's low, it's low. If it's normal, I'm probably not going to repeat it unless something dramatic changed. But like I said, treatment failures, because it helps us down the line in terms of, is this somebody who is so procoagulant that effectively therapeutic anticoagulation failed to stop them getting another clot, or is it because they were under anticoagulated to begin with?
Thank you, helpful. We've sometimes checked pre-dose levels, with some of the inducers to see, are we just clearing the drug really quickly, so we're leaving quite a long time when they've got low or no levels of the DOAC. So with carbamazepine and enzalutamide, but mostly been okay actually, which is interesting. And yeah, they are, we talk about expected ranges with our patients. Go on, it's where we'd expect it to be. And I don't know, if we've done it in someone that's on enzalutamide. We haven't done it on 80-kilo male patient of the same that's not on it, so we don't always know, but I suppose it gives us a little bit of, well, looks about okay. So as far as we can tell, you're absorbing the drug and hopefully it's doing what we want it to. But yeah, so just not heavy reliance, but sometimes helpful for a bit of a reassurance by the sounds of it there. Timing wise, I'll just do one more question and sort of link to something I wanted to ask you as well. So if you've already started your patient on low molecular weight heparin and then you're switching to DOAC, obviously apixaban 7 days of 10 milligram BD or rivaroxaban 15 milligram BD, if you're switching them within those timeframes, do you go on to the sort of initial doses of your DOACs, or would you sort of take that bit off of how many days of low molecular weight heparin, or does it depend on your patient? Kieron?
It's a good question. I get asked this a lot. It's a very pragmatic answer. I think it depends. What do we know? Well, if you look at the DOAC studies, they excluded everyone from the studies who had more than 72 hours of anticoagulation beforehand. The reality is we don't really know anything greatly from data. I'm a little bit pragmatic with this. High risk events, I probably include most of my cancer patients in this. If it's sort of within that sort of 3 to 5 day period, I probably would give the full load-in regime. Out of that, I would probably subtract it, but I've got no real good data to back that up. And like I said, we only know what we know with this. But just an important point on load-in, it's not pharmacokinetic load-in. The rationale for it is based upon this idea that in that acute phase, there's a higher risk of thrombotic recurrence, and it comes from an earlier drug called, I always pronounce this wrong, xylagotran.
Yeah, that's pretty good.
It's close enough, isn't it?
I think that's close enough.
It's close enough. It's close enough.
Yeah,
It's close enough. They did in their studies, they didn't have loaded doses. They went back and looked at the data and they suggested it was a bit higher. So it's not pharmacokinetic, it's high risk periods, high risk patients.
Yeah. Nathan, anything different or anything to add?
No, very similar. I think it does vary a little bit from person to person. I think if it's been 72 hours or less that they've had parenteral anticoagulation, I just ignore it and just give them the full loading. If it's beyond that, then it depends. Sometimes if they've had a big, massive PE and they've got, I tend to think, oh, well, actually, it's probably better to give them loading. Whereas if they're very frail and little and they've had a calf thrombus or something, then I'm sort of a bit less concerned, really. So yeah, it's a bit variable, I think.
Yeah, I think one of the things I wanted to ask around that, I suppose, we talked about bleeding quite a lot, and obviously the increased risk of bleeding in CAT patients. And one of the things that's bothered my haematologist definitely, in the 10 milligrams twice a day of apixaban is quite a lot of apixaban. I appreciate what we're trying to achieve in that, but it's quite a big dose, especially if you've got someone with maybe poor renal function, maybe somebody of that's already at an increased bleeding risk. So I guess, do you take that into account when you're thinking about what you're putting them on, or whether I want apixaban but I feel a bit uncomfortable about the 10 milligrams twice a day? Is that something that bothers you at all? Or?
You have to be a bit practical about it sometimes, don't you? And you think, well, I know this is the licensing, but I mean, I think you have to be practical and consider everything. And I think occasionally it is reasonable to think about using a lower dose sooner, isn't it? Based on overall, and actually a lot of these patients aren't patients that are adequately represented by these studies anyway. So I think it's very reasonable to use your own clinical judgment, isn't it? You know?
Yeah, absolutely. And I think, obviously there's licensing and other bits, but I think, it's important just to think about the patient in front of you. I think you presented that well in terms of what do people actually want, and having that conversation, because we'll get referred people and go, no, they're hating injections, they need an oral. And then you're like, but you've got quite a large tumour in your colon, and the studies suggest, all right, I'll carry on. It's often about that conversation, isn't it? And about the understanding for them, and they can make that choice and they go, yeah, but if you can see me in a month again when I've had it resected, you're like, okay, then I'm happy to continue for now as well. We're at 1 minute to 3. We've done an extra 15 minutes, and that has been fabulous. Thank you so much, Nathan and Kieron. A brilliant run through around cancer-associated thrombosis for 2 of the country's leading pharmacy experts in the cancer-associated thrombosis. Your patients are very lucky to have you. Thank you so much for sharing that, and I hope you have all enjoyed the session today. Thank you very much.